Good afternoon, and welcome to today's webinar titled Power from Potential, Making Clinical Data Your Most Valuable Investment. My name is Jeanette Wider, and I'm Managing Editor of Healthcare Innovation. Today's program is sponsored by Infor. Thank you to our sponsor and to our audience for giving us your time and attention today. Before we get started, we have a few housekeeping details. To submit a question, please use the Q&A box to the left of your video window at any time. You do not have to wait until the end of the program. For technical issues, please press F5 to refresh, and if that doesn't work, you can submit a question with your issue through the Q&A panel. Finally, join our webinar conversation on Twitter. You can tweet using the hashtag HILiveWebinar. At this time, I'd like to introduce Dr. Paulo Pino, Vice President and Medical Director of Innovation at Diameter Health, and Rob Brull, Senior Product Director at Infor. I will pass this over to you guys. Thanks.
Hi, my name is Paulo Pino. I'm a VP and Medical Director at Diameter Health, and we'll talk a little bit about some of the challenges that we experience with clinical data, some of the opportunities that exist with clinical data. Prior to my current role at Diameter Health, I've been a practicing physician for about 2 decades and worked in the corporate space in the employee health, concierge health, and global health divisions. And so really looking forward to talk about how to really sort of extract the potential out of data with Rob. And Rob, I'll turn it over to you.
All right. Thank you, Dr. Paulo. My name's Rob Brull. I'm the Senior Product Director at Infor, and I have responsibilities for our innovative products, which are based on the new FHIR standard for driving interoperability. I'm also the subject matter expert for standards, so I am a certified Ccda specialist, certified in FHIR, deal with standards a lot, and look forward to discussing interoperability standards and semantic interoperability today. So with that, let's get started. First, we're going to talk about legislation and standards, where we're at, where we've come from, where we're going to. Then we'll talk about data volume, velocity, and variety. And then we'll talk about solutions. How do you solution for the future with regards to interoperability, and how do you put together that ecosystem? And then finally, we'll wrap it up with use cases. All right, so first let's talk about meaningful use and the Cures Act, essentially where we've been and where we're going. So first, let's talk a little bit about meaningful use. So meaningful use was good for the industry. It helped us get everything electronic. But it did fall short with regards to interoperability. So there were some components of interoperability and meaningful use. There were the transition of cares, which sent CDA documents, summary care documents, and continuity care documents for any transition of care. There was the FHIR API based on DSTU2 that got into the later stages of meaningful use. But beyond that, there wasn't this real data sharing between organizations that was driven by meaningful use. So now looking towards this decade, we can look towards the 21st Century Cures Act, which kind of picks up where meaningful use left off and can propel us into more integrated interoperability or seamless interoperability moving forward. So there's 2 rules that have already been released that are tied to the 21st Century Cures Act. The first is a final rule that was released in March of 2020. And it was based on interoperability and patient access. So there were some rules or some mandates in there that are all based, well, are primarily based on FHIR that require the payer-payer data exchange. They require notifications to be sent, but also patient access to payer data. And that patient access started in meaningful use with patient access to provider data. Now it's been transitioned for payer access to or patient access to payer data as well. So that's the final rule that's in place already, and we've seen those, mandates, deadlines actually be met, except for the payer-payer data exchange, which has been extended. But there's also a proposed rule that came out in 2020, later on that year, that kind of added additional things to the interoperability front related to prior authorization, which is also known as burden reduction, and then also provider access to payer data. And that rule still remains in a proposed state. And so we have these things from a governmental perspective kind of pushing us forward with regards to interoperability. But then there's lots of other things going on in the industry as well. The one example here is the Da Vinci Group, which is an accelerator group at the HL7 organization, which is pushing interoperability forward with regards to 14 specific workflows listed here. Now, some of these workflows tie into the government mandates. You can see that there's 3 that were in that final rule, and there's another 4 that are in the proposed rule. And so there's definitely the workflow details around how we achieve those CMS rules that can be gleaned from the Da Vinci implementation guides. But then there's also 7 additional workflows that are not in any rules yet. So these are market-driven workflows that are, worked on by the HL7 organization to kind of give us a leading indicator of what's important to people and what type of workflows can we use to solve challenges moving forward in healthcare. So it's always a good idea to keep your eye on what the Da Vinci Group is doing and other accelerated groups in HL7 to figure out, what are the leading edge workflows and what challenges can we solve moving forward, especially with regards to the FHIR standard. Now, I've talked about FHIR already, which is the new standard, but the reality is that, most of our data that we share today is not FHIR based. It's HL7 V2 based, and then those continuity of care documents that are being sent for transition to care. So we have, a fair amount of CDA, but all the majority of the data that we see going through that's event-based data is still being sent by HL7 V2. So let's take a little overview of these so we can understand what are the challenges with our existing standards, how do we utilize them and kind of bring them forward and then, move into the FHIR-based era of the future. And so with HL7 V2, it's a message-based architecture. It's a string of data, just delimited based on pipes and hats. The learning curve is relatively simple, I would say, if you can just count the pipes, count the hats, and figure out what data goes where. It's good for structuring the healthcare data and has served us since the 1980s in transferring data in healthcare. However, it's not good for mobile apps, and it's not good for getting data on demand. So with HL7 V2 messaging, it's push-based messaging. So we have this inability to kind of go get the data when we want it, which presents some challenges. With CDA is a type of document. It's sent with messages often. So for transfer of care, often a secure email is sent and the CDA document is attached to it. The CDA document does have the ability for semantic ontology. It is a relatively complex standard to figure out, though. It's based on the RIM or the reference information model, and specifically CDA is based on a subset of that called the RMIM or the refined message information model. But it is all-encompassing for all these workflows in healthcare, and because of that, it became really complex. So to try and parse that data out, even though it's XML-based, you need specialized tooling because you're looking at any data types and mixed choice nodes, and it's just a really complex schema with regards to the XML and the way it's encoded, which just presents some challenges on getting at that data and using it. And then finally, FHIR is meant to solve these challenges, right? So the HL7 organization, when they came out with FHIR, they said, let's look at what we've done in the past. Let's look at CDA, let's look at HL7 V2 and make them all better. So moving towards FHIR, we have what's called resources, which are these right-sized packages of data that can be sent around. They are have enough information to be useful, but not so much information that they're hard to work with. FHIR is built on the modern technologies of HTTP web services and JSON and/or XML. It's relatively easy to learn, and then people who are used to using HTTP tools and JSON tools can just use those with FHIR. So the learning curve is less, the tooling is less. There's lots of examples, lots of reference implementation guides, and so they're trying to make FHIR really easy to implement for the future. All right, and so just a few slides that kind of drill down and just show you what those standards look like in case you're unfamiliar with HL7 V2. It's just a delimited string. So you see all the pipes, you see all the hats, the data is submerged in between. If you know what you're looking for, you can find it, but you need specialized tooling like an integration engine or some other tool to really parse apart that data and get at it. And that makes it really unfriendly for apps and modern development. This is an example of a CDA document which uses XML, and it doesn't look that unwieldy here, but this is only a very small snapshot, which is the CDA, which is the human readable portion of the CDA document. But the CDA document, when you get down to the entries and the clinical details, can become really unwieldy, making it have its own set of complexities as well. And then finally, FHIR. So FHIR is based on XML or based on JSON and or XML. We primarily see JSON being utilized in FHIR and HTTP web services, which makes it app friendly and makes it a more innovative standard to be utilizing moving forward, which is why the Cures Act picked FHIR and said, with these mandates we have coming forward, we're going to utilize FHIR. And so just a summary with regards to FHIR. Why did CMS mandate FHIR? One, because it uses modern technologies. Two, because those right-size packages focus on the 80% workflows, and then it's extendable from there, keeping the core standards simple. And then the data is organized in a very nice way where you can take these resources, these right-size packages, and then combine them together for your specific workflow that you want to solve. And so with that, I'm going to turn it over to Dr. Paulo and let him talk about the gaps, despite the the standards that I talked about.
Thanks, Rob. So I think Rob did a really good job of summarizing where we've come from a interoperability standpoint, and really the goals of making data available for patient care at the provider level, at the population level, for payers, et cetera. And so here we are, essentially 2 decades beyond meaningful use, and we still haven't achieved nirvana when it comes to interoperability. There's a couple of things that I want to talk to you about as potential causes for this. So to start off, I want to just kind of speak to the current unrealistic expectations of EHR. So whenever providers are in the process of being trained, if you've ever been at a hospital and kind of seen hospital rounds, it usually consists of multiple different providers, some physicians, some nurses, medical assistants, et cetera, that may all be on site. And there's a rich dialogue going on. And so what they're doing is assessing a patient for what complaints they came in for, what tests have been done, and evaluating what those tests shows, and trying to come up with a differential diagnosis. And that differential diagnosis is sort of a rank order list of all the things that are possible for that patient in terms of a diagnosis, and then all the potential medical treatments, all the potential diagnostic tests, et cetera. When you finally leave the residency and the training aspect of care and you go out into the real world as a provider, that same sort of dialogue that creates that rank order list at the bedside is how every provider thinks. So if, for example, I have a patient that's a 20-year-old female and she has chest pain and she's on oral contraceptives and she's been on a flight recently and she has some shortness of breath as well, and she's a smoker, I may think, hey, you know what, the top order diagnosis that I'm thinking about is probably a pulmonary embolus. But there are other things that could be there. She could be having musculoskeletal pain. More unlikely, she could be having a myocardial infarction or a heart attack. It could be, that, she had chest trauma a couple of days ago. So there's a whole host of possibilities in terms of that differential diagnosis, and providers set up that probabilistic thought process in their head. When providers document that, it becomes semi-structured. They get documented in a progress note, and it usually is in something called SOAP format: subjective, objective, assessment, and plan. Providers will document all of the things that are in the history, that are material to the diagnosis, any findings that they find on physical exam or labs, then come up with, hey, I think it's this diagnosis, and lastly come up with what I'm going to do is prescribe this, this, and this, and the following tests. Electronic health records have further constrained this. So we go from essentially semi-structured data to now very structured data. And so a lot of this really Socratic kind of internal monologue that happened with providers gets lost. And that internal monologue effectively doesn't get transmitted into the electronic health record. we have expectations that the electronic health record is going to tell us about all that internal monologue. And this graphic really kind of shows what we're expecting, this constraining of the flow of data, but yet sort of this expansive expectation. When in reality, to some extent, what we really see is this. We see very limited amounts of structured data that provide overall insights into what's going on, perhaps some semi-structured data that's in the EHR that provides greater insights, but certainly not everything that existed at the point of care. The next thing I want to do is I want to talk about documentation. And so documentation, what I think people fail to realize from a provider standpoint in the United States, is driven by a couple key central tenets. Number one is we want to document what's going on at the point of care to the best possible, but we also want to make sure that we fulfill all of the requirements to be able to bill, all of the requirements to be able to capture risk, all of the things that are necessary to protect ourselves from a medical legal standpoint. And we also want to exude something that the patient is going to see and still like us as providers and still trust us as providers. And so I want to give you an example, and this is me at the bottom in that picture in my younger days with more hair. What this shows is how typical documentation happens at a provider by a provider. So this is 58-year-old male. Past medical history is reported as hypertension. Medications are amlodipine. Presented to an urgent care center with a chief complaint of a head laceration. And in the history of present illness, there's a whole narrative. He sustained it with a fall at home while gardening. He was walking in his backyard. He tripped over a brick. So you could see there's a lot of insight here. You can also see that the patient had no chest pain, shortness of breath, any weakness. Those are all pertinent negatives. And then you can see, with the exception of the above, the review of systems was negative. Anything that's highlighted in blue is really our structured data elements. Anything that's not highlighted is some of that semi-structured, unstructured data that kind of gives you some insight into what the provider was thinking, but maybe not all the insight that they were thinking. And as we move on, you see that vital signs are structured as well. And so here's the example of vital signs. You also see that on physical exam, effectively it was a normal physical exam. The skin showed a 3-centimeter clean laceration in the right frontal scalp, which was the only finding. We then move to the diagnosis, and you see that a diagnosis code is actually standardized, and there you have an ICD-10 code. We move into a procedure, and in this case, the procedure was actually a code for a simple superficial scalp repair, and then there's a plan of care that's part of that procedure. The plan of care also includes that a follow-up a week later for suture removal. So you can see what's structured and unstructured, and I want to give you a caveat about data. And again, this is getting back to the medical legal protection that providers are looking to get, and also the fact that patients have access to their data, and it needs to be presented in a way that still retains that trust from a patient-provider standpoint. And so you can see, while suturing the patient, the provider noticed that while it was 9:30 a.m. on a Saturday morning, he reeked of alcohol. He, again, looked to protect himself medically and bill appropriately, and again, maintain that superb patient satisfaction scoring that he's had. And he documents, while suturing Mr. Smith, the intense smell of ethanol was noted in his breath and in the room. No other stigmata of alcohol abuse were noted on history and physical examination. And so when we look at the truth about electronic health records, and I did a side-by-side comparison here of what typically gets put in a portal, which is at the selection of a provider. I want to talk about what typically goes to claims, and then I want to talk about what exists in the electronic health record. And you can see the electronic health record has the most robust combination of that structured and semi-structured data that we spoke about. Obviously, you're seeing that things like hypertension is found in there, the medications that the person's on is found in there, the presence of a head laceration, et cetera. You can see that as you kind of move over to that middle column, when it comes to actual documentation from a billing and coding standpoint, and when it comes to claims data, the only thing that really comes in is any claim and any ICD-10 or any problem that was diagnosed at that visit. So you don't get insight into this person's hypertension, which is important from a risk selection. And so the hope is that that hypertension is being treated by another provider and that there's other claims that kind of create that lattice work of data that's so important. And then as you move over into that portal, you could see the combination of yellow and red, which may not make it into that portal, because of the fact that some of it can actually, with prior to 21st Century Cures Act, with blocking, could actually be limited. And so that EHR at the source is really the best source of the clinical truth. Again, with the limitations that we spoke of, in terms of the structured data, in terms of the semi-structured, and the absence of that really kind of Socratic monologue that's so critical to care delivery. The other thing that I wanted to kind of address is that in addition to point of care issues, there are a couple things that are happening with just the data revolution. And this will address some of the challenges that we've experienced, despite the fact that there are standards when it comes to interoperability. So volume of data has increased and its velocity of transaction has increased. And the reason is because it's ubiquitous. We look at 76 HIEs, they cover more than 92% of the US population. So there's data on a significant chunk of the US population that come from electronic health records and is housed in organizations like health information exchanges. When you look at the percentage of physicians that are using electronic health record, the percentage of physicians is substantial. 90% of physicians are using electronic health records. However, only 72% of all physicians are actually using certified EHR. And this is relatively recent data provided by the CDC, as well as provided by SHEIC, which is the Association of Health Information Exchanges. And so there's a lot of data exchange. There's some of that data exchange that's not necessarily subject to the interoperability standards because of the fact that we're not dealing with certified EHRs. In addition to that, the amount of healthcare data is just increasing exponentially when it comes to patient care data. And so you can see in the United States, there's about 1 billion health encounters annually, and it's increased by about 900% since 2016. So volume of data is just huge, and it's staggeringly increasing, as time moves on. In addition to this, there's substantial variety when it comes to the data, and I'll show you some examples a little later of how raw clinical data, on average, despite the fact that there are specific standards for how that data needs to be exchanged, 50% of it doesn't adhere to standards to the point that it is often unusable and inconsistent with care delivery. And this is because on top of the fact that there's a lot of data, there's also millions of different ways to represent data with different coding systems, et cetera. And so that's contributing to the issue. To put things into perspective about what this costs us, it's about $30 billion of the annual US healthcare cost that is attributable to the challenges with interoperability. In addition to that, and this is not necessarily patient data, this is around medical data and the science of medicine. So the science of medicine has a staggering increase in the doubling time is actually decreasing substantially, as evidenced by the amount of data that comes from clinical trials, et cetera. So in 1950, it took 50 years for medical knowledge to double. By 2020, it's now down to 73 days. So we're talking about every 73 days, the full body of medical knowledge is going to change over. To put things into perspective, and there's a little statement there, a medical student starting medical school in 2010 will only know 6% of their discipline in terms of knowledge in 2020. So having standards is critical. Having standards that are adhered to, having a way to make sure that we're really capturing clinical intent and that we can marry that clinical intent to the medical data that exists there to drive outcomes is tantamount. So we talked about variety and lack of usability. I want to give you a couple of different examples. So this is actually the LOINC code for hemoglobin A1C. Hemoglobin A1C is a common test that's used to diagnose diabetes. And you can see from this single point, which is actually what it should be, you can see all of the different ways that an electronic health record platform is going to document hemoglobin A1C. And this is actually only 38 of about 150 different ways. So if you're looking to do analytics, or you're looking to even compare consistently within a patient, having 150 different ways to document hemoglobin A1C poses a substantial challenge to that. And you would think that on the heels of a pandemic, that we've fixed that problem, but the reality is that we haven't fixed it. And so this is actually the variation in how COVID-19 testing, a PCR, is documented as positive or negative. And here are an example of a handful of them, when in reality, there's about 40 different ways that we've seen data represented at a state level for COVID-19 PCR negativity. So just the negative concept is oftentimes represented with different codes, different display names, et cetera. And so it's not limited to just labs, and you could see over on the right, 18% of inbound lab data is actually valid and valuable and consistent. You could see that it's also a challenge when it comes to other clinical domains as well. And you can amplify what it means with other clinical domains, just based on the scale of what we're seeing with labs. So aggregate across all clinical domains, 49% of inbound data comes in according to standards, interoperable and usable. Vital signs, for example, 57% of the time. Sometimes it's missing units, sometimes its display name is wrong, it's not coded appropriately, et cetera. So this is the reality of clinical data usability and why we have such a challenge when it comes to ensuring that it actually is practiced despite the fact that it's legislated. And so in terms of solutions, I'm going to turn it back over to Rob, and he'll speak to some of the solutions that we've addressed in our respective companies.
All right, thank you, Paulo. So let's talk about the strategy for modernization. How do you get access to all this data so you can then utilize it? And we've all heard about data being trapped in data silos. Part of the reason that data is trapped in data silos is because there's no good API to get it out. We're dealing with this legacy way of exchanging data with HL7 v2. And so we've got some tools in place that we can utilize to get at legacy data and expose that in a modern-based way. So we want to use that to unlock the data silos. We want to then leverage that data in the legacy systems and extend your legacy systems. We don't want to get rid of your legacy systems and say that just to achieve true interoperability, you got to throw everything away. We want to embrace your legacy systems and extend them into the interoperability ecosystem. And then the last thing, the challenges that we solve is just the transition to the cloud. So as we move into a more nimble and robust way of interoperability, there are lots of updates and upgrades and changes taking place with implementation guides from HL7 and workflows being managed. That's much easier to do in the cloud because the cloud automatically keeps you up to date versus an on-prem solution having to constantly schedule your upgrades and time them with other things and plan ahead. That type of benefit of being able to just stay up to date with the latest standards is a big benefit of positioning, moving to the cloud, not to mention the infrastructure costs and other benefits of moving to the cloud. So what are the steps for doing that? So I have 3 steps listed here. The first is access. We want to get access to that legacy of data and expose it in your new FHIR ecosystem. Once we get that data exposed, we want to orchestrate it and make it available in a modern-based way. And then third, we want to assimilate other apps, other very focused ways of dealing with the data. We want them to have access to the data through. So we want to have that app enablement as well. All right, so let's first talk about access. With access, like I said, one of the reasons that data is stuck in silos is because of the legacy way of dealing with those systems. That could be HL7 v2. It could just be, proprietary database access. It could be X12. It could be any legacy standard. So we have a FireBridge product that we can utilize that is very adept at communicating with legacy technologies, and it's based on our Cloverleaf integration engine, which has been around since the beginning of all those legacy ways of exchanging data. So we're very good at going and getting legacy data. We can bring that out and then through our FireBridge product, expose it in a modern-based way. So then once you have access to that data, you want to be able to expose it and allow orchestration to happen based on that data. And we can do that through a FHIR server and also by supporting other standards like Smart on Fire, which enable consistent access and registration and authentication to that data. So we take the data that we've gotten from the legacy system, we put it in a Fire server that will allow that data to be accessed on demand. So now your app development teams and other apps can get access to that data whenever they want it in a modern-based way, which leads me to step 3. Then you can focus on, okay, what apps are important to my organization? What challenges do we need to solve, and what apps are out there to do that? And immediately bolt those apps into your new ecosystem and get them access to all the data, including that legacy data, so that then those apps can work for you to solve your challenges. And with that, I'll turn it back over to Dr. Paulo.
Thank you very much, Rob. So in terms of kind of orienting this, we saw a patient example earlier. Rob, articulated access, orchestration, assimilation of data. But I think one of the pieces that's really critical as well is just ensuring that you have semantic normalization of data. It's not just making sure that data can be transacted from one physical place to another, but also making sure that there's actually a transaction of that data in a way that allows that data to communicate similarly across all different care settings. And patients are very complex. They often receive care in multiple different care settings. And this is the example of Jane. And this is only 4 visits, but you can imagine even a more complex patient over a longer period of time. This is a patient who's been seen from 2019 to 2021, just to provide an example. So she's 68 years old. At her primary care visits in 2019, she's diagnosed with hypertension, hyperlipidemia, episodic low back pain. She's diagnosed with she's prescribed a host of medications for those, and as you can see, they're all listed there. And this is highlighting 2 clinical domains. It's not addressing, for example, allergies. It's not addressing lab results. It's not addressing procedures. It's not addressing radiology reports, et cetera. It's only addressing these 2, right? And so her whole story is really all of this that was here before I started fragmenting here. But you can see where every single care episode she has creates a new group of data that also provides some of that unfortunately providing added data also provides so in a way that's fragmented. And so here you have, she's diagnosed with a posterior low myocardial infarction. She's admitted to the hospital and put on a host of medications as well. And lastly, she goes to an urgent care center. And at that urgent care center, she's diagnosed with acute bronchitis and she's treated with medications. Turns out that poor Jane also was diagnosed with COVID. So there's COVID test results, et cetera. And so what we really want to do is we want to create, really one data asset that really speaks the same language. It's kind of like getting everybody together at the UN and saying, hey, everyone just speak their native tongues and we won't have any common language. Having that Esperanto language, that sort of middle ground that everyone can communicate is really, really important. And what we find is that not only is there challenges with interoperability between EHR platforms and care locations and providers, we also noticed that there's actually intraoperability. So even within the instance of the same EHR, epic to epic, there's different implementations that have data that's transacted in different ways. So really getting not only the languages common, but the dialects common is really important. And so where Diameter Health fits is actually, squarely in the middle, right? So you have this onslaught of data that we talked about, the volume, velocity, and variety, pretty well typified by the river. We know that we have downstream applications that we want to fulfill, things like risk engines, population health platforms, et cetera. And what you need something that's going to serve as that translation data, something that's going to take the power of all of those conversations that are happening at the UN, like a common language, and allow that to be exchanged in a way that really drives outcomes and impacts. And so where we sit again is squarely in the middle, in that hydroelectric dam space. And so what do? We take the different clinical domains, and you saw in Jane, I gave the diagnosis, and I also gave the medications, but there are all the clinical domains there that you see on the left. And we do a process that we call fusion, where we normalize to data standards, things like ICD-10, SNOMED, RxNorm, et cetera. We enrich the data with key pieces of metadata. We add, for example, drug class that really allows you to look at allergies, at the class level instead of at the individual drug level. We add, for example, a clinical classification system to a diagnosis so that when we downstream will go and deduplicate that deduplication is thoughtful, and it deduplicates chronic conditions, like someone who's seen 15 times for hypertension probably doesn't have 15 diagnoses of hypertension. They have one diagnosis of hypertension for which they're seen 15 times. But someone who gets a cold, every month may actually have 15 colds. And so you'll see all of those, as well as whether or not it's an active problem or it's become a past problem. So that's the importance of the enrichment layer. We reorganize data so that it's in the correct sections of the clinical chart. We saw, for example, with COVID vaccinations, that we were seeing them, come in as medications. We've seen that with vaccinations in general. We see things like, for example, procedures, which should be in the plan of care because they happen at a future date, but they come in a procedure section, sort of fooling an end user to thinking that the person actually had the procedure done. We talked about deduplication. And lastly, we summarize. We create this longitudinal summary of data, and I'll explain how the outbound of it looks. But this fusion process, or NERDS, N-E-R-D-S, really enables analytics, population health, risk adjustment, et cetera, et cetera. And so Rob talked about some of the clinical data inputs that we spoke of previously. CCD is actually listed here, so you'll see that. You'll also see that there's HL7V2 messages. You'll see that there's, in addition to that, certain organizations present to us flat files and also FHIR. And so effectively what Diameter Health takes this multi-source, multi-format clinical data, and the bread and butter of what we see is really the CCD. And we will run it through our fusion process, and we'll outbound data really fit for purpose. And organizations that are using us are ingesting that data once in whatever format or formats they ingest that data, and we outbound it in something that's fit for the purpose that it's intended to. So, for example, we provide an outbound CCD that's been, fusionized or upcycled is our term for it. We'll provide a longitudinal CCD that really talks about the entire care journey for that patient. We have a proprietary JSON model that really serves as the anchor by which we map to CCDs, longitudinal CCDs, FHIR, our tabular data extracts and flat files. FHIR is also what we can provide as well. Tabular data extracts for things like HEDIS, et cetera, is another way that we present data. And so it's really, again, ingest the data in, fix that data so that it's semantically interoperable, and then outbound that data in a way that an organization can use it in multiple different ways to fulfill multiple different use cases. And so what have we seen in all the time that we've been working on this? So this is the example of the 14 top EHRs by market share. And you can see that there's a fair amount of, CCDs that we've processed, fair amount of patients, and 55 million clinical data elements. And you can see by domain, when the source data is good and fulfills the criteria set forth for interoperability, when we perform an uplift or upcycling, and then you can see that there's some of that data that's, not fixable. And the reality of it is that we can infer things that aren't listed in a chart. And so the reason why we don't get to 100% is because of the fact that new ways of documenting show up, inconsistent ways of documenting show up. There's missing data, or there's data that shouldn't be in a particular area of the chart that really provides no clinical insight into that domain that it's speaking to. Like we've seen, for example, in a diagnosis or a problem domain, we've seen procedure codes, right? It doesn't make sense in that particular area. And so here's what we take as inbound data, what we ultimately will upcycle it. And you can see that there's the top 14 EHRs. We've, in our history of working with this, almost come up with a fingerprint for what the data quality looks like by EHR, by its implementation, et cetera. And so you would think that, if you narrow this down to the top few, the data becomes seamless and it's better and there's no issue. It's not always EHR specific, it's provider specific. It's the way providers interact with that EHR. But we can kind of give you an insight what the top 4 EHRs by market share is. And, while in some domains there is improvement there, it's not, 100% improved. And you can see this is, again, based on 400,000 CCDs, 139,000 patients, and over 33 million data elements. So, what we really ultimately do by taking this data and upcycling is ultimately, defragment patient care. Take this multi-source, multi-format data in different EHRs, by different providers in different care locations, and we create one longitudinal data asset that you can look at in various different ways and at varying different degrees of episode versus longitudinal. And we take that data and we upcycle it so that you have one data asset that captures this multi-source, multi-format data and really is lent towards analytics, patient care, outcomes, population health, et cetera. So how do Infor and Diameter begin to stack solutions together? And I'm going to turn it back over to Rob to talk about the Infor solution stack.
Thank you. So I'll talk about the products that we have at Infor to kind of expose your data, so then Diameter Health can do the enrichments and the data fit for purpose and the upcycling. So with regards to exposing the data, get access to it, we have two products which are key, the FireBridge product and the FireServer product. So I talked earlier about access. FireBridge is the bridge between your legacy systems and exposing that data in a modern way. So FireBridge has pre-built configurations in it that allow you to go get HL7v2, X12, other data types, and then expose that via Fire so that it can be more easily accessed in a modern way. We also have a FireServer product, which can then persist that data and make it available on demand, versus FireBridge is a transactional type tool. And then to complement those two products, we have the API Gateway product, which is an outer security layer, which you can use to manage all the apps that are trying to access your data and provide that security layer for all the devices on the internet that are going to need to and are going to want access to that data that you have available. And Paulo, I'll turn it over to you for the next slide. I believe Paulo is on mute still.
Oh, sorry about that. You heard me speak previously about the concept of data fit for purpose. And so you see on the left the different places that patients' data comes from and where they receive care. You see the different data types and how that data comes in and how it's transacted. And you see where fusion exists in sort of this architectural diagram and how we feed this data into an enterprise data lake that then allows different use cases downstream, like the analytic use cases, the patient rate of access. We also have a data quality opportunity as well. And so for things like patient provider to provider communication, CCDs are really well lent to that. Fire again is well lent to things like eventing. As you're looking for breakouts in certain communicable diseases, et cetera. As you look at patient right of access, you can see the tabular data or the HEDIS extracts, which is the purple layer there. And lastly, again, our data quality layer that is comprised of rules on completeness and syntax of inbound clinical data that really support identifying gaps in data to upstream providers to change their behaviors in terms of how data is inputted and ultimately improve how outcomes happen. We'll show you a couple of examples moving forward. And so when you look at where Diameter Health and Infor interact, you can kind of see the opportunity, for interaction. And Rob, do you want to comment on this? But so I'll turn it over to you.
Yeah, so just real quick, Infor has lots of partners. We can, be the base foundation for exposing data, and then we help companies expose data so that organizations and/or our partners can take that data and, do their thing with it, right? And in this case, Diameter Health can do all the things that they talked about.
Awesome. So moving on to the next slide. So what does this mean? So we talk about some of the challenges with inbound data. So let's look at, this is a high-risk patient. It's actually a true patient, and it's a patient in a 375,000 problem study across a whole host of different patients. But you could see key risk diagnosis like type 2 diabetes, heart failure, COPD, vascular disease, and ischemic stroke come in with no SNOMED code, perhaps no ICD-10 code. In addition to that, they may only come in with a display name or a free text string that comes associated with that. And so what we do is actually populate the data asset on the outbound, so it really is lent towards a rules engine or an analytics engine. And so you could see 64% of these diagnoses contain blank or free text code. There was no translations for those. We were able to normalize about half of them from that free text source. Again, we can't normalize if it syntactically doesn't make sense. And when we did normalize that, we normalized that to an ICD-10 code, which is critical to driving, engines, either prospective or retrospective engines. And you could see that about 31% of diagnoses contained a valid SNOMED code with no translations. And when that happened, we were able to upcycle that to 97% valid codes. And again, those were again in ICD-10 code format. So taking this patient and kind of extrapolating this forward, you can see anything in green is really where the opportunity to upcycle the data lent itself to HCC appropriateness of coding. Anything that was in white or gray was what the native data showed if you lent that to an engine. And you could see that there's a substantial impact on HCC code or RAF, and you could see that RAF uplift and what that means from a annual payment lift for a particular complex patient. And if you extrapolate this across a population, we've shown that we've increased the capture of diagnoses like diabetes by about 52%. And in addition to that, the member impact that we've seen with a large national payer, you could see is between 0.234 to 0.337 RAF impact for that particular patient. So you're really getting accurate risk scores. You're really identifying true diagnoses, the validity of clinical intent, and you're providing on the prospective side an opportunity to improve the way providers document. Rob?
Thank you. So this use case is a prior authorization use case, which is also part of the 21st Century Cures Act. It's a proposed rule right now, so we don't have the final dates. But prior authorization is seen as a big burden on the industry. It's also called the burden reduction initiative within that proposed rule. The idea being that right now there's a lot of activity that has to take place with regards to getting prior authorization approved. It could be phone calls, it could be cutting and pasting data into a payer portal, it could be faxes, it could be any number of things, but it's a lot of backroom activity. And all of that with the proposed rule is moving to a FHIR-based solution. So, at Infor, we're working with the HL7 organization, the Da Vinci organization, to put the products in place to where instead of waiting, a day or two or three to get your prior authorization back, the idea is that with FHIR-based APIs, that could happen in seconds or minutes versus having to wait, a day or two to get your prior authorization back as to whether you've been approved. Another big initiative or use case is patient cost transparency, and this is about getting a good faith estimate. This relates to the No Surprises Act, and also many of the states that are putting initiatives in place where good faith estimates must be provided. So traditionally, payer-based communications has always been X12. With patient cost transparency, it's moving to a FHIR-based communication now. And so Infor has the infrastructure in place to be able to do those conversions between FHIR and X12 so that those good faith estimates can be made in a modern FHIR-based way and give the patient the good feeling of what they're actually going to pay up front versus being surprised later on. Paulo?
Thank you. And so lastly, you saw some of the data that I presented on COVID-19 lab reporting and some of the challenges that we faced because of the lack of interoperability when it comes to COVID-19. There's real opportunity at both the state and federal level to really rinse and repeat what's been done in that study, which was actually performed in the state of California, and extend that to a whole host of other diseases and a whole host of other data. And so when we speak longitudinal data assets, it could be longitudinal for a patient's entire care history throughout their life, but it could also be throughout a care episode. And so if you imagine collecting lab data, marrying that lab data up with vaccination registry data so that you can find the impact of vaccines on positivity and negativity, the time that the time difference that happens in terms of somebody converting to positive after they've been vaccinated or have gotten a booster. All that information can really be gleaned, and you can get some good insights. On top of that, adding provider data really starts to allow you to kind of look at severity of disease. You can find whether or not people that are vaccinated or people that have had multiple COVID episodes have sequentially worse COVID episodes, or have chronic lung damage from it. Those are all the things that if you start to marry that multi-source, multi-format data that comes into a state, you can really glean population health insights and really provide, a substantial map of the gaps in care, of the opportunities to improve care, of the opportunities to identify new outbreaks, et cetera. This process currently is very manual at the provider level. There's an opportunity to automate this, and I think the automation of this is really through data assets. And so with that, we'll conclude. I see that there's some questions in the chat. And I'll actually take one of the questions. So one of the questions is around, will FHIR replace CCDA? And so I think that, in terms of where we are, CCDA did not replace HL7v2 messages. I think that there's a place for FHIR. I think that there's a place for CCDA. I think when we showed that data fit for purpose slide, you saw that that data fit for purpose slide really had both on the outbound. To the most robust, comprehensive, way to exchange data right now is, probably CCDA. The most transactionable, you can send little widgets of data or resources of that data is probably FHIR. Rob, anything you want to add? And maybe you can take one of the questions.
Yeah, so there is documents in FHIR. So when you look at the FHIR standard, there's documents and messages that can be FHIR based as well. You kind of package up those resources similar to the way you have sections in a CDA document. So it'll be interesting to see how that plays out. I don't think we know yet, but certainly there's options there for FHIR to take over. Yeah, so one of the questions came in about what do I really need to get started with my FHIR ecosystem, or really my interoperability ecosystem? Do I need all the things you presented on the slide? And no, they're modular. So one thing I want to point out is that, when I looked at our architecture, I had our Cloverleaf integration engine for our legacy integration engine connected to the legacy systems. If you have a different integration engine other than Cloverleaf, you don't have to rip that out. You can leave your legacy HL7v2 engine there, and then you can come in with a FHIR product and convert it to more modern data to help get that legacy data into the ecosystem. That's kind of the first step. And then modularly, you could choose a FHIR server, the Infor FHIR server, or you can choose the API gateway product. But you may already have your own API management product, or you may have another FHIR server. We can certainly package it all together for you, but it's all modular, and we can work with you to fit into your existing infrastructure and grow with you to make sure that that data is as much data as possible is exposed so that it can be utilized and enriched and everything else.
Awesome. And there's a couple of them that I'll take in association with one another. One is about the intersection of clinical and claims data and the value of having both. And the other one is around social determinants of health and whether or not there are solutions that are involved for that. I think one of the challenges with social determinants of health, and I think we can kind of use this statement to answer around how clinical and claims data will interact with one another, is that providers document in varying different ways. So a social determinant of health may be something that's in a plan. A social determinant of health may be something that's in a social history. It may actually be something that comes in sort of the history of present illness, of that provider note. So there's not really been a lot of standardization. US CDI is driving towards that, but there's still a substantial variability. And remember, again, what we spoke about in terms of why documentation happens. It happens not only to capture clinical intent, but it happens to drive outcomes. And if there is no endpoint for some of those social, determinant of health documentation at the provider level, there are going to be some gaps there. Also, it drives, medical legal protection. And so if we say that Mrs. Jones has problems paying for her medications and a medication is prescribed that she ultimately never fills, whose responsibility is that to kind of address that? And lastly, again, remember that with increasing transparency, some of these social determinants are, maybe inferred at the point of care. And so, to say that, Mr. Smith is illiterate, and somebody in Mr. Smith's family identifies that, and Mr. Smith now addresses that with the provider, there's something about the physician-patient relationship there, provider-patient relationship that gets altered. So it remains to be seen, I think, how it's going to be documented. There are a lot of solutions out there that address it, in questionnaire formats, inferences from other data elements that come in. So it's really the intersection of a whole host of different data that's really going to be vital, to how we begin to capture things like social determinants of health in terms of care outcomes. Rob, I'll let you speak, and it looks like we're kind of right out at time, but certainly are available via email if anybody has any additional questions. Would love to answer those.
Yep, same here. I don't have anything to add. So thank you all for your attendance today.
Awesome. Thank you.
Bye-bye.